If you want to reach your full potential, that means growing, and that means being willing to fail. It means being willing to put yourself out there and be vulnerable.
Hello, and welcome to the Clinicians in Leadership podcast series. My name is Zach, and I'm joined today by Dr. Chris Baugh. Dr. Baugh, do you mind taking a second to introduce yourself and tell us a little bit about your experience?
Of course. Thank you, Zach. So my name is Dr. Chris Baugh. I'm an emergency physician, and I work at Brigham and Women's Hospital, which is one of the Harvard-affiliated teaching hospitals in Boston. I'm an associate professor of emergency medicine, and I've been at the Brigham for almost 20 years at this point. I did my emergency medicine residency at the Brigham and Mass General's combined emergency medicine residency program. And prior to that, I did an MD, MBA combined degree program at the University of Pennsylvania and Wharton Business School. I've worked in a series of leadership positions during my time as an attending physician, first starting with medical director of the observation unit at Brigham and Women's Hospital, followed on by being medical director of the urgent care center that we opened in Foxborough, Massachusetts for about 5 years, and then became medical director of our main academic emergency department. In 2018, I became the vice chair of clinical affairs and recently completed a 5-year term in that role.
That's awesome. Well, thank you again for Dr. Baugh for being here today and joining us on this Clinicians in Leadership podcast series. As I was looking through your resume and poring over your LinkedIn, that like you in what we just heard from you right now, you have extensive experience both on the clinical side of medicine as well as the administrative side of medicine, and that started going when you were going through medical school, graduating with both your MD and your MBA. Both of those are amazing accomplishments on their own, but to do that together. And so my question is, you have had a number of experiences both in this clinical and administrative side of medicine. What has been some of the more impactful ones, the ones that you have taken some lessons from, the ones that have stuck with you throughout the course of your successful career?
That's a great question. I would say in these operational roles that I've been working in, I feel like there is never a shortage of urgent I think problems to solve. I think one of the challenges in a role like that is kind of separating the urgent from the important and being able to both take care of the day-to-day operation, but also be forward-looking and be able to put into the works these longer-term strategic initiatives that take maybe months or years to really come to fruition. If I had to pick one particular challenge that stands out in my career, I'd have to go back to the early days of the COVID pandemic. I was about a year and a half into my vice chair role in an academic emergency department. These days, there are often multiple different vice chairs in charge of different things. And so there's a vice chair of education, could be a vice chair of faculty affairs. I was the vice chair for clinical affairs. And so it was very clear that the ownership of how our department was going to respond to the pandemic really fell to my leadership. And so that was an opportunity for me to stand tall and think about how I was going to support the patients coming through the department and our staff taking care of them. And so if you can recall back to those early days, we had PPE shortages, there was no vaccine, there was a lot of, I think, unknown. That was really a scary time to be working in the emergency department and to be a patient. And so this was an opportunity for me to really be a visible leader in my department, my hospital, and my health system. One of the challenges that our staff was facing was changing guidance that was coming from multiple different levels, from the hospital, from the state, from the federal agencies. And sometimes that guidance would change within one day, and it was very confusing. So one of the things that I really focused on was authentic messaging. I did a daily message where I curated all of the information into one daily message. I put data into that message. There was a lot of, I think, misconception around the volume of, say, COVID patients coming through our department, what the inpatient capacity was like, what our ICU capacity was like. So I wanted all of our staff to really see what the data was showing and kind of remove kind of misinformation from the conversation. I also had this message come from not just myself, even though I pulled it together and sent it to the staff, but really have our nursing leadership, our APP leadership, all be with my name at the signature line. So this was a unified message. It also gave staff an opportunity to contact me directly with any questions or concern they had. And then on the next message, I could go ahead and answer that for them and be responsive. And so this was a strategy of communication that I think really helped us. I think morale is also a big challenge. I ended up on the signature line for each of these message having the phrase strength and love, because I feel like at that time we needed both of those things. And I like to think that the way that I helped our department respond really made us survive and thrive in that situation that was incredibly challenging.
No, and that was, I mean, the word thrown around all the time was unprecedented times, and it truly was. And you had just all across the country and across the world, you had very, very impactful and accomplished healthcare leaders who had never experienced anything like this before. And so it truly was just a trial by fire. Everyone was going through it. And one word I thought that was really interesting that you used, specifically when we were talking about your role as the vice chair of clinical affairs, is you viewed it as an opportunity. And I think that that's something that's a unique approach that not a lot of people that I have interacted with viewed the COVID pandemic as a unique opportunity to stand strong and to display effective leadership. So how do you cultivate a mindset that views things, even terrible things such as that COVID-19 pandemic? How do you cultivate a mindset or develop a mindset that sees everything as an opportunity?
That's a great point. I think at the time, the way that I saw it that really helped me have the right mindset was that all of the things that I thought had been challenging in my career were really kind of pushed me to grow, or was maybe difficult during the time, but I felt like maybe I was better off for having gone through it, was essentially training me for that early days of the COVID pandemic. And as a result, I think, grateful for the challenges I had gone through, because I felt like I was ultimately a more effective leader because I had been forced to grow. I think there's a discomfort in growth, and I think it's natural to kind of not seek that discomfort, to actually stay away from it. But ultimately, if you want to reach your full potential, that means growing, and that means being willing to fail. It means being willing to put yourself out there and be vulnerable. And so that's kind of the mindset that has, I think, served me well over the years. I think there's a phrase from the Stoics that's called amor fati, that I like to think about. It's love your fate. I think the idea that we can't control what happens to us, but we can control how we react to it, is a really helpful mindset that I think takes a lot of the kind of personal persecution perception out of what happens to us in our daily life, and say, hey, it's not personal. It's just happening to me. And now it's how I respond that's important. There's a book called Crucial Conversations that I've read that I think is really helpful. And it's about kind of how you control how you react to things. And this is really relevant even day to day when I'm working clinically in the emergency department. I might have a very tense situation with a patient or a family member or a consultant or an admitting doctor. And the idea of kind of being able to see yourself from the third person and not get emotionally activated in those situations, and really keep the patient at the center of the conversation, has been a really effective tool set for me that I'd like to think makes me as a better clinician and a better administrative leader.
Well, and I want to talk a little bit more about your experience in the emergency department, and how that experience from the clinical bedside, serving as an emergency physician, emergency medicine physician, has affected your leadership, because you've served in leadership both in that emergency room setting as well as in a variety of other areas. And so, what has been the impact of your clinical experience on your approach to administration?
I'd like to think it makes me a more effective administrative leader for having spent the time in the clinical arena. I think when you're actually seeing patients and working shifts, I think the emergency department's a little bit unique because we have to work 24/7. And so I've always really prided myself on being able to work not just the morning shift or the afternoon shift, but being working in the evening, working overnight shifts, working weekends, working holidays, because the emergency department doesn't always run the same at different times of day or day of the week. For example, a lot of resources in the hospital that are available in the middle of the day, midweek, are not available on a Sunday overnight. And I think when I'm thinking about an operation solution to a problem, being sensitive to that fact, I think helps me create a workflow that is ultimately more useful. It's more useful for my colleagues who might be nocturnists. It's more useful for that patient coming into the emergency department at 2 a.m. versus 2 p.m. So having that direct experience to understand that, I think, is quite helpful. I think there's always a list of things that need to be fixed in a department, in a hospital, in a health system. And I think working clinically gives you the perspective of kind of where the gaps are and how important those gaps are for patient care or clinician wellness or different things that we're trying to optimize. And so, unless you're actually having that experience, I think it can be very challenging. Now, you can try and get some of that experience if you're not working clinically. You can spend time shadowing in the department. You can have clinicians that are partners, that are mentors, that you kind of run things by. But for me, it's been invaluable to actually be taking care of patients while I'm also working on these process improvement and operations projects.
Well, and another component I think that is fascinating about your career thus far has been your involvement in research, and we haven't necessarily talked about it thus far, but you are pretty extensively published with research studies and articles in the New England Journal of Medicine, amongst other journals. Can you tell us a little bit about just your research experience and how that has combined with your clinical experience to make you a more efficient administrator and leader?
I think research and developing a research niche where you can become a deep content expert is a great part of my career, where I get to travel around, give talks, give grand round talks. I get to write papers and really have this deep knowledge of different areas. For me, it's observation medicine, it's accelerated diagnostic pathways, and that really dovetails nicely with the administrative work that I've done, it being our observation medicine medical director or being the vice chair of clinical affairs, where things like accelerated diagnostic protocols are very important to having relationships with consultants, to efficiently moving patients through the department, to having a level of safety around the way that we're evaluating things. For example, patients with chest pain and our approach to cardiac biomarkers and stress testing, et cetera. And so it's been a nice complement to the clinical and administrative work that I've done. And the way that I think I've set it up, which has allowed me to publish quite a bit, is really to never miss an opportunity to write about some of the administrative work that I've done. I think people who are heading into administration oftentimes don't have the ability to find the time to do the writing, and it can be a challenge to start writing. Just staring at a blank page or writing a grant for the first time is very difficult. But it's like any other skill. The more times that you do it, the easier it gets and the better your skill set is. And so that's just been something that I've tried to over the past, say, 15 to 18 years, to publish several papers per year to get, into triple digit papers. And if you look at what I've written, it's largely clinical operations. One nice thing about clinical operations work too is that it oftentimes can kind of fill the category of quality improvement, which often doesn't need IRB approval, oftentimes does not need patient consent, randomization, things that take a lot of time and money to pull off as a research project. If this is like, hey, we're doing a before and after around a pathway for taking care of patients with low risk GI bleed, you can just implement that as a quality improvement project, and then you can publish your data as a quality improvement project later. And so I've really tried to be disciplined around saying, hey, for a particular project, can we write a paper just describing our process for reaching consensus and creating a pathway? And then we can publish the pathway, and then we can publish the before and after study of how the pathway performed. And so all of a sudden, for one administrative project or operations project, I have 3 or 4 papers. And then once you get papers out into the universe, I feel like people will come find you, and all of a sudden you'll have someone reach out and say, "Hey, we're doing this study that's similar to what you're doing. We'd love for you to join us as a co-author." And all these positive follow-ons come from I think writing and putting your work out to the universe. For me, I like the idea of doing a literature search or review whenever I'm looking to solve a problem. I'd like to think that the problem that I have is probably a problem for other people too. And so I think the skill of doing a lit search before you start coming up with solutions on your own is very valuable. And I'd like to think that the literature I put out there into the world is part of someone else's lit search, and all of a sudden that maybe something good that I did is being implemented in another institution, and so in that way I can become a bit of a force multiplier in terms of clinical medicine and not just directly care for the patients that I'm seeing in the emergency department or in my hospital, but for patients all around the world potentially.
Oh yeah, and I think that is such just an amazing part and component that without research you can't have that extended impact. And that is research is a way, especially published research articles in all these journals, is a way that other administrators, like you just said, can review your process and what you have accomplished and then implement it in their own. And you're paving the way in a lot of ways for these other administrators and healthcare organizations. And I love the way you described it as a force multiplier. I thought that was fascinating. And that, like you said, that extends beyond just the care of the patient in the bed in the emergency department, which is still very, very important. But it's a way that you can affect patients in emergency departments all across the country and across the world, and that's awesome. Um, that doesn't come without some challenges, though, I would imagine. And so, what are some key challenges to integrating research and some of these evidence-based practices that you've talked about into administrative policies?
It's a great question. If you look at what we do in medicine that's rigorously evidence based, it's actually probably the minority of what we do. And so when there is something out there that is evidence based that we should be doing, I think we need to be doing everything we can to make sure that that's part of our daily practice. And so the idea of keeping up with the literature, with reading a lot, being able to assess the literature. So even if you're not writing papers yourself, I think being able to read a paper and kind of understand the methods, understand the results, and ultimately the limitations, and whether that paper is going to change the way you practice, I think is a critically important skill. I think even non-clinicians should have some familiarity with how to read a research paper. But ultimately, when you're trying to have an administrative policy, protocol, workflow, whatever you want to call it, I think the first step is to become a content expert on that particular problem, and that means doing a lot of reading. I think then once you become a content expert, you pull together a stakeholder group of anyone that workflow is going to be touching. And I think importantly involving nurses, APPs, and other folks who are going to be caring for these patients is also an important group to include at this step. Then ultimately, you're going to develop what the new workflow is. You're going to start with a version 1, and by the time you share it with everyone, it might be in version 10, but you got to start with something. I always tell people that the first draft doesn't have to be good. It just has to be written, right? So I think having the courage just to put something on paper, share it, and start iterating is very important. And then once you have this new workflow, I think the idea of in service of getting it out there, making it accessible to folks in the areas where it's going to be applying to them, whether it's electronically or I've certainly had the experience of laminating a workflow, posting it up on the wall next to where people work, and then ultimately data. The idea of having access to data to first of all make the argument to people that change is needed. That's going to be part of the in-service to say, hey, there's a gap and this is going to help close the gap. But ultimately to say, hey, what you're implementing, doing what you wanted it to do, is it making a change? And any change that you had initially with perhaps success of a launch and some of the PR that goes with it, is that success being maintained? I feel like very often we launch something and then we go to the next project and we say, job done. And I think that's only a wrong way of thinking about it. I think the idea of sustaining change can be sometimes harder than the initial launch. And so those are all kind of perspectives around the life cycle of kind of operations change that are always in the back of my mind when I'm taking on a new project.
Well, and I think it's interesting. You just talk about sustaining change. Change is something that is inevitably hard for a lot of people, and especially when you were talking about workflow and the way that they have done their job for a number of years and habits. Changing something is that's always hard. And so, how do you, as a clinical leader, promote buy-in from fellow clinicians and from administrators when research or evidence points towards making a change? How do you promote and sustain that? You just talked about that a little bit.
Yeah, I think you need to know your audience. I think if you're talking to clinicians, you have to make it about the patient. How is this change going to ultimately change patient outcomes, patient experience for the better? And that means, having, as I mentioned before, some data to suggest that there's room for improvement, and that the change that's being proposed is really going to move the needle. And if you have the research to back that up, to say, hey, for example, several years ago, my department was one of the first to become X-waivered to be able to write for buprenorphine for our opioid use disorder patients. There was a very compelling case for buprenorphine that was evidence based, right, around reduced relapse rates, around safety, around preventing mortality in this patient population. I think anyone who went through that presentation didn't, you had to leave that being like, hey, this is the right thing to do for us to have this capability. And it was launched at the same time that we also opened a bridge clinic. So it was a great new workflow where the emergency department could initiate, and then the bridge clinic could take over the care of these patients. And so ultimately, it really activated us as clinicians to say, I know it's this new information that we have to learn, and there's a new workflow. We have to learn about how to write for this and assess patients for it. But we were willing to do that because we knew it was the right thing to do. I think administrators also, for sure, are interested in patient outcomes, but I think they also think about things in a bit more of a business lens, in that they think about return on investment when they're trying to figure out which projects to tackle and which ones to really prioritize. So that ROI around what's the investment going to be? Is that investment in a new staffing role, new hours, a new resource, a new piece of equipment? And then what is that expected result? And how does that translate into dollars? And then so is that every dollar spent, what's the dollar amount that is going to be an improvement? And they want to be seeing a multiplier, right? So they want to see, if I invest $1, I get $3 back in savings or improvement. Ultimately, these administrators are trying to prioritize what they're funding, and they can't fund everything. I think someone once told me, you can solve infinite problems if you have infinite resources. But we operate in a capacity and resource constrained environment in healthcare, right? So we can't solve all of the problems, at least not all at once in the near term. And so the administrators are trying to do their best with the resources they have available to say, hey, this is what we're going to put forth in this year's agenda. They're fighting for a budget every year. And so I think if you can speak to them in that language, I think you'll be more likely to be successful in getting your project supported by them. And ultimately, you need that, especially if there's any kind of investment from the hospital that's required.
Well, and I think you put that very gracefully and eloquently, talking about the tension between the business side of healthcare as well as the patient care side of healthcare, and both are equally important, in the sense that if you're not doing one well, you can't do the other one well. And that I think that you navigated that very in a very concise but accurate way, and that just speaks to the importance of having someone with experience in both fields, being able to see from both perspectives, having them involved in change and implementing new workflows and research and evidence-based practices. And I think that you put that really, really well. Can you give us an example of where research findings have influenced an administrative decision or a policy change within the hospital system that you work at?
Great question. I think one example that I could go into a little bit is our home hospital program. So this is now going back maybe 6+ years. We had this idea that shifting the location of inpatient care away from the main campus hospital into the community was going to be an important strategy for the future. We were full back then, we're even more full today. And so, in order to get that program started, we actually had to start as a research project. So we started with randomized controlled trial where we randomized patients to routine care, which was inpatient admission. You can take the elevator ride up to the tower, have your normal admission, as has been the case for years, versus going home with the home hospital team, where they can do remote patient monitoring. They can keep an IV in the patient. They can bring some diagnostics, some limited radiology, lab testing, medications to the patient's house. They could visit the patient in their house, et cetera. And we had a number of conditions that make sense for this type of care, things like pneumonia or heart failure. And then we actually studied, how those patients did in the two arms, and essentially found that the home hospital program didn't have any worse safety events. They had higher satisfaction. They had more mobility during their hospitalization. So as you can imagine, in your own home, you're up and about more, which is important to prevent deconditioning and other kind of risks of being an inpatient. And it was also lower cost. And so I think that very positive trial gave our health system the confidence that this was the right thing to invest in for the future. And then now, for the past several years, our home hospital program has been one of the most ambitious parts of growth of our health system. Right now, I believe we have the largest home hospital in the United States, with the idea that that home hospital is still going to grow by a multiple of 3 or 4 in the upcoming years. And that all started as a research project. And so sometimes you have to kind of show it's going to work on a smaller scale before the hospital or health system is willing to really invest in building up something way more ambitious that wouldn't have happened spontaneously.
So we've just as we can get ready to conclude, just one final question for you. For administrators without extensive research experience or necessarily without the ability to conduct research, what advice would you give to these individuals who are looking to strengthen their knowledge base, their approach to research? What advice would you give someone that doesn't maybe have the experience that you have in the research field?
I would say there's many educational opportunities out there, most of them free, that really help you acquire some basic skills that can be very helpful. I mentioned earlier around how to assess a research paper and kind of know whether it's high quality, low quality, whether it really should change practice. There are many different workshops, tutorials, et cetera, that are available for kind of folks starting their careers. It could be for medical students, it could be for junior faculty. And the idea of, as an administrator, kind of auditing one of those workshops to sit in and kind of get more familiar with different types of study design, the limitations, et cetera. I think that's probably time well spent. I've also personally, I've included administrators as co-authors in some of the projects that I've done, especially ones that are very heavy operationally, and maybe the administrator helped with some of the data acquisition and analysis. So they legitimately contributed as a co-author. I think being involved in that process, where maybe you're not the first author or last author, but you're a middle author and you're getting some exposure and you're seeing how that process is, would be a lighter lift that would be more accessible to an administrator without a research background. And then ultimately having a network of folks who have research as a strength to kind of turn to as an advisor or a mentor would be another piece of advice. I think in research, mentorship is really critical to success for anyone's career. So the idea of an administrator saying like, "Oh, this is my go-to person to send. Oh, I saw like an interesting article come out. What do you think of it?" And having that trust to say, "Oh, their reaction could be very valuable. I have my own reaction, but theirs might validate that or challenge that to say, oh, I didn't really read it the same way. what can I learn from what you just told me. I think being open to that would be very helpful. So those are all different ways for administrators to really, I think, improve the way that they look at research, and ultimately, I would think, become more effective administrators because that's part of their skill set.
Well, thank you, Dr. Baugh, for joining us today on the Clinicians and Leadership podcast series presented by the American Journal of Healthcare Strategy. I know I greatly benefited from this conversation, and I know our listeners will as well. And so thank you for joining us today, and we hope you have a great rest of your day.
Thank you so much, Zach. It was a pleasure talking to you. Take care. Bye
Take
bye.
care.